And now it is my huge pleasure to introduce David Weber, coming to us from CHOP today, who will be our speaker. David, thanks so much for being with us.
Thank you, Laura. Let me go up here. All right, am I good to go?
You're all set. Thank you.
All right, great. Thank you so much, Dr. Tosi, for the opportunity to talk today. So I'll be speaking about the clinical spectrum of ENPP1 and ABCC6 deficiency. A few disclosures before I start. I have done some consulting work for PTC Therapeutics. I've participated in a Duchenne muscular dystrophy colloquium lecture series, and I do have some grant funding from Innazim. This is an investigator-initiated observational study of monoallelic ENPP1 disease, and today I will be discussing non-FDA approved medications. Objectives today. I hope you all can recognize the spectrum of bone and mineral disorders caused by ENPP1 and ABCC6 deficiency. Understand the proposed pathophysiology underlying the disordered bone and mineral metabolism of these disorders. And then become familiar with current and future treatment options for ENPP1 and ABCC6 related disease. I really find this condition fascinating. I should say I'm relatively new to this field. I came to CHOP about 2 years ago as an attending, and our program here has a strong relationship with our cardiovascular center, and so we get asked to care for some of these children. And I really find it just a fascinating condition, and there's such a wide spectrum of disease. So just wanted to highlight that here on this slide. So think about a female fetus presenting at 28 weeks gestational age with echo brightness of the aortic and the pulmonary annulus, echo brightness and narrowing of the descending aorta and iliac arteries. And then think about a 12-year-old male presenting to clinic with bilateral knee valgus deformity and lateral patella subluxation, biochemical findings of hypophosphatemic rickets in the absence of any prior medical history. And then a 54-year-old mother of the above male who reports chronic back and joint pain, has had 2 minimally traumatic long bone fractures as an adult, and has been diagnosed with osteoporosis based on low bone density by DEXA. And these conditions respectively represent generalized arterial calcification of infancy, which I will refer to as GACI throughout this talk, autosomal recessive hypophosphatemic rickets type 2, AHR2. And then the third is really a question mark. Could this be an adverse effect of monoallelic ENPP1 mutations? So these are all different clinical presentations of defects in the same gene. So I thought I would just try my best to do a mini review of what we understand about the physiology of mineralization. So this figure here from Lanzer and colleagues in 2021, I think did the best job I could find of trying to unify the different players as we understand them. It is a very complex regulatory pathway. First, just to highlight in this figure here, these red stars actually represent aberrant mineralization in soft tissue. And when we think about this pathway, there's 2 things going on. On the one hand, there's a need to prevent unwanted mineralization of the blood vessels, of the organs, of connective tissue and other soft tissues. And then we want to be able to permit wanted mineralization of the bones, which of course we think about all the time in terms of pediatric bone health and skeletal development. So how does this happen? So let's start with inorganic pyrophosphate, or PPI. This is a critical inhibitor of calcification in the blood. Then let's think about something we all know and understand, tissue non-specific alkaline phosphatase, or ALK-Phos. We, of course, think about ALK-Phos as hydrolyzing PPI into inorganic phosphate, and this allows for bone mineralization. And of course, the deficiency that we all are comfortable with is ALK-Phos deficiency, underlying hypophosphatasia, and these patients have that undermineralization of bone. Today, we're going to be focused on the opposite spectrum of this. So we're going to be talking about ectonucleotide pyrophosphatase phosphodiesterase 1, or ENPP1. This enzyme is responsible for the synthesis of PPI, as well as adenosine monophosphate via hydrolysis of ATP. So ENP deficiency then results in low PPI, thereby promoting aberrant mineralization where we don't want it. And then additionally, low levels of AMP ultimately seem to lead to narrowing of the major blood vessels. Together, PPI and AMP deficiency lead to GACI. And then biallelic ENPP1 loss of function mutations are the most common cause of GACI. We'll talk more about this in a minute. A few other players to know: ABCC6, the ATP binding cassette subfamily C member 6. This protein is involved in the transport of ATP into the extracellular space. The full mechanism is not entirely known, but we do now know that ABCC6 deficiency leads to low levels of ATP in that extracellular space, and then ultimately end up also with low PPI and low AMP. And it is a less common cause of GACI. ABCC6 deficiency also results in a condition called pseudoxanthoma elasticum, or PXE. One more player just to briefly mention that I won't really get back to today, but there's another important protein called CD73. It hydrolyzes AMP into adenosine and inorganic phosphate. There are mineralization disorders due to deficiency of this protein as well. Presents typically in adults as calcification of large joints and arteries. This protein is encoded by the NT5E gene, and so biallelic loss of function mutations have been described. And it's thought that the low adenosine does two things. One, it again leads to that narrowing of the blood vessels, and then perhaps is also increasing that alkaline phosphatase activity, promoting aberrant bone mineralization. And then I'm just going to highlight that there's really much more to this story than I understand, and perhaps any of us understand, as many patients lack any of these mutations. In fact, the last several patients that have come through our clinic, we haven't been able to detect mutations in any of these genes. So let's move on then to talk about the clinical spectrum of ENPP1 and ABCC6 deficiency. So two main genotypes we're going to focus on today. That's going to be ENPP1 and ABCC6. And several phenotypes, as I alluded to. So generalized arterial calcification of infancy, again, GACI, PXE, AHR2. And then I'll briefly talk about coal disease, which is a dermatologic condition. And these are extremely rare disorders. The incidence for GACI has been reported at 1 in 200,000 births. PXE, a bit more common, but still quite rare, 1 in 25 to 1 in 50,000. A recent paper out of Carlos Ferrer and his group did estimate that ENPP1 deficiency as a whole is a bit more common, 1 in 64,000 pregnancies, but still very rare. And then coal disease, there's really no epidemiological data I could find, it's so rare. And then there's overlapping phenotypes of these conditions. I'm going to have some figures here. These are not to scale, just my best efforts at trying to demonstrate this. So in the simple cases, we have PXE due to biallelic mutations in ABCC6. And we have GACI due to biallelic mutations in ENPP1. A subset of GACI is due to ABCC6. And then some patients with PXE have ENPP1 mutations. Most patients with ENPP1 mutations go on to develop the hypophosphatemia of Ricketts. And then we have a small subset up here of coal disease, that dermatologic conditions with some overlap of both AHR2 and GACI. So let's try to sort these out a little bit better. So let's just talk about a comparison of GACI and PXE. So as I mentioned, the genetics are a bit different in that GACI is most commonly caused by ENPP1 rather than ABCC6, and the reverse is true for PXE. For GACI, the presentation is typically in utero or shortly after birth, whereas for PXE, it's in adolescence or later. The clinical signs of GACI are going to be calcification and stenosis of the arteries. It's associated with a very high infant mortality. And as I mentioned, the development of Ricketts later on in life is very common. For PXE, the major clinical manifestations are going to be skin papules and plaques, retinal streaks and hemorrhages, early onset atherosclerosis and related cardiovascular disease, and the development of Ricketts is uncommon in these patients. Here's some pictures to help us sort of understand the clinical phenotype a bit further. So here's some ultrasound and CT scan images of a patient with GACI. And that first panel, C1, this is a prenatal ultrasound. So often this is the first sign that there's an issue. You can clearly see the calcification of the aorta there. The second panel is the same patient who had an ultrasound done at day of life 14. You can still see some calcification of the aorta and the iliac arteries, although you will see it does look like that calcification is already starting to resolve, which is characteristic, and we'll talk more about. And then finally, there's a CT scan there in the third panel, representing the stenosis of the aorta, the celiac artery, and the SMA. Here are some pictures of the clinical phenotype characteristics of PXE. So in the panels F1 and G1, you can see the characteristic skin findings, these pseudoxanthomatous skin lesions. And then F2, G2, and G3 show some of these retinal images illustrating the angioid streaks and the cherry red spots. There's a spectrum of PPI concentration in the blood related to which disease you have. So as you might imagine, the PPI level does appear to be somewhat dose dependent with the number of alleles involved. And we're talking just about ENPP1 genetic mutations in this figure. Here's a paper out of Ralph and colleagues illustrating ENPP1 levels in different families. I'll point you first here to a healthy control. And so you can see here's the quote unquote normal PPI level. And then our light gray bars are going to be family members who have a single mutation in ENPP1, and you can see their levels are roughly half that of the healthy controls. And then in the black bars are our patients with biallelic mutations. 2 of these patients had GACI, and you can see very low levels of PPI here. And then 2 of the patients had PXE. Levels are still quite lower than the heterozygous patients as well as the healthy controls, but are numerically higher than those patients who had GACI. At this point, it's not exactly clear if the PPI level associates with the clinical severity and the mortality in GACI. Part of the challenge with these rare diseases is there's so few patients, it's hard to really do these studies and find statistical significance. Wanted to talk a bit more about the natural history and showing some paper from Carlos Ferrer and his group who've really done a lot of work helping us understand the phenotype of this condition. As I mentioned, the infant mortality is extremely high, approaching 50% of affected children. And the cause of death can be myocardial infarction, can be heart failure, can be multiple organ dysfunction. Mortality does appear to be higher in those with ENPP1 disease versus ABCC6. Here's a Kaplan-Meier plot just showing some of the survival curves for different individuals. What I really want you to highlight is just this steep mortality there within the first days to weeks of life. So much of that mortality happens shortly after birth. And then things do tend to level out. So if you sort of survive that early infancy period, chances are pretty good. One of the really fascinating aspects, or I think fascinating aspects of this disease, is that these calcifications decrease or resolve completely with time. Unfortunately, however, the vascular stenosis seem to persist, and they can persist into adulthood and are really responsible for a lot of the adverse cardiovascular disease. The mechanism by which the calcifications resolve is not known. I want to highlight a paper here by Ramirez and Suarez, who tried to characterize this longitudinally with some follow-up studies in affected patients. Again, it's a small study being a rare disease. So they looked at first set of postnatal imaging and found that about 63% of those patients had stenosis on that first imaging study. And then about 75% had calcifications. When they followed these patients forward longitudinally, only 1 of the 5 or 20% had resolution of stenosis over the next few years, whereas all of the patients who had longitudinal imaging had calcifications resolved. Want to move in then and just talk more about the Ricketts AHR2. This is a form of hypophosphatemic Ricketts. It is biochemically and radiographically similar to XLH. Here's a classic picture. This is from a case report by Coe and colleagues in 2022. This is a 24-month-old infant with AHR2 due to biallelic ENPP1 deficiency. You can see a bowing of the lower legs there and metaphyseal changes, as we might expect in other forms of hypophosphatemic rickets. It does appear that there is phosphate wasting in this condition due to elevated FGF23 levels like XLH. The etiology for this is not entirely understood. One theory is that this may be a response to the low levels of pyrophosphate. Thinking here is because there's low PPI and a mineralization promotion milieu in the blood, that there's a response of increased FGF23 to try to get rid of excess phosphorus. It's also possible that there's some direct result of ENPP1 deficiency on FGF23 regulation. So ENPP1 is expressed in osteocytes and osteoblasts. So it's possible we're just somehow losing inhibition of FGF23 with the loss of function of ENPP1 in the bone. As I mentioned before, most GACI survivors due to ENPP1 deficiency do go on to develop AHR2. Although another fascinating aspect of this condition is that not all patients with AHR2 had GACI. So some patients will just present in childhood or in adolescence with rickets, be found to have ENPP1 and have no history of GACI or no history of cardiovascular disease. I'll present one of my patients who fits that phenotype. Briefly talk about coal disease here, so a bit outside of our realm, but just for completeness. It's an early onset form of punctate keratoderma and hypopigmented macules, as you can see in panels B and C there. It's an uncommon and, from what I understand, a benign skin condition. It can be due to either monoallelic or biallelic mutations in ENPP1. What's interesting about it is the mutations all tend to occur in this one domain of the ENPP1 gene, SMB2, and it's thought that ENPP1 is involved in melanin transport and keratinocyte development, and that is leading to this dermatologic phenotype. Another important characteristic of these conditions that I think sometimes we may forget as bone health clinicians is that there's a high risk of hearing loss. And so hearing loss is common in survivors of GACI, both patients with ENPP1 and ABCC6 genotypes. One paper here by Thin and colleagues from this year did describe that 53% of survivors of GACI and 50% of the ears had evidence of hearing dysfunction. This tends to be conductive more than sensorineural. Etiology is not fully understood. 55% of these subjects did have abnormal calcification. Recurrent otitis media was also common. There's a thought that perhaps this calcification is contributing to osteocular chain dysfunction. In animal models of ENPP1 deficiency, it also has been shown that the micromorphology of the ossicles appears to be abnormal. You can see that in the figure A here. If you look at the bottom panel of the ENPP1 affected mouse, there seem to be decreased mineralization heterogeneity and lower levels of osteocyte lacuna. And then just want to briefly mention this interesting area of the question of whether monoallelic ENPP1 can be a cause of osteoporosis. And so there's some emerging evidence supporting a link between monoallelic ENPP1 deficiency and skeletal disease. Part of this just comes from some anecdotal family histories that you get when talking to the parents of our children with GACI and AHR2. Mouse models of ENPP1 deficiency do exhibit osteoporosis. And previously, a SNP variant in ENPP1 was found to be associated with risk of hip fracture on GWAS. So just in the past couple of years, there's been a couple of really interesting publications describing this possibility in a bit more detail. First by Oheim and colleagues here, looking at human heterozygous ENPP1 deficiency being associated with early onset osteoporosis, similar to what was seen in the mouse model. This was an interesting study where they actually did a phenotype study of 172 patients who presented with early onset osteoporosis of no other identifiable etiology. And two of these patients ended up having these monoallelic ENPP1 loss of function mutations. So they did some further testing of the families. Highlighted here in the blue bars, the ENPP1 hets. And then now highlighting the bone mineral density Z scores. And so, as you can see there, it does appear that those Individuals who are heterozygous for that ENPP1 deficiency have lower lumbar spine and total hip Z scores than their unaffected family members. Not shown here, they also had lower serum phos, sometimes at the lower end of the normal range to just outside the normal range. And then a second paper came out the next year, identifying 2 additional patients with monoallelic ENPP1 deficiency. They had low bone mineral density, also had abnormal spinal ligament ossification. These patients also did have lower serum levels of phosphorus and elevated FGF23 levels. Let's talk a little bit more about possible ENPP1 genotype-phenotype relationships. With the exception of cold disease, there's no clear genotype-phenotype relationship that has emerged. So you can see from this diagram here, the majority of the mutations underlying GACI and AHR2, as well as PXE, come in the catalytic domains of this gene. The relationship with residual enzyme activity is unclear. You might expect that patients with less residual ENPP1 activity would have more severe disease, and that may be true. And again, we may just not be able to detect this based on the small sample sizes. A paper by, I believe this was Mercurio and colleagues again, looked at individuals who had truncating versus non-truncating mutations. And they did find that those with the truncating mutation who are presumably producing a less effective protein and probably have more residual enzyme activity, survival was higher in that group at 67% versus those with non-truncating mutations and presumably producing no active ENPP1. Moving on a bit then to some clinical diagnostic considerations. Like any rare disease, I think you just have to have an incredibly high index of suspicion for these disorders. For GACI, really anytime that there is echo brightness of the great vessels or the cardiomyopathy on the ultrasound in the fetus, that should be a potential warning that this could be GACI. And then for infants, any idiopathic cardiomyopathy, hypertension, or pulmonary hypertension without a cause, remembering that the calcification may already have disappeared by the time the infant is born, and so that might not always be there. For ARHRT, really we're looking at phosphate wasting rickets that's not due to PHEX mutations. And then for PXE, it's going to be those characteristic retinal skin findings and then early onset atherosclerosis that I discussed. Any of the above should prompt consideration for these disorders and testing of ENPP1 and or ABCC6. There's no currently clinical available test for PPI in the blood. It is available as a research test. We have a colleague, Dr. Lee, here at Jefferson, who will run them for us. Recently, there was a paper publishing reference data for one of these research methods. You can see that there by Bernard and colleagues in 2022. I do believe there's a clinical assay in development, so this may be an option in the future. So let's end here by talking about the current treatment approach for GACI. And really a multidisciplinary team is essential. So we're going to have close collaboration with our cardiologist, depending on the severity, our intensivist and our neonatologist, our colleagues in genetics to help make the diagnosis, as well as sort of us and our expertise in helping manage bone mineral metabolism. And the cardiovascular treatments, of course, will be dictated by our cardiologists, and they're really going to be trying to ameliorate the effect of the arterial stenosis. And this will be a combination of antihypertensives as needed, things like ACE inhibitors, angiotensin receptor blockers, and beta blockers. Typically, there's some antiplatelet and anticoagulation treatment started in infancy. Aspirin is typically used. In many cases, there's going to be a need for cardiorespiratory support with ventilator, ECMO. And then in some cases, heart transplant may even be necessary if we have progression to heart failure. I actually was interested to see that there have been reports of heart transplant for this condition. There's a paper by Giovanni and colleagues reporting a heart transplant and 2-year follow-up of a child with GACI. This is an 18-month-old female who had GACI due to ABCC6. Transplanted for end-stage heart failure. You can see the explanted heart there. Notice the ventricular hypertrophy, a thickening of the heart muscle, and then all the scarring here from myocardial infarction. And what I thought was really interesting about this is that 2-year follow-up study showed no calcification or no stenosis of the transplanted coronary arteries. Again, just really sort of highlighting the fact that this disease really seems to have so much of its clinical effects during early fetal and neonatal development. So how do we treat this? So it's really tricky, and there's no good clinical trial data to guide us. So because of the devastating mortality of this condition, people have been willing to really sort of try things and sort of look at ways to try to prevent calcification. And so there's a couple different approaches here. One is to try to prevent new calcification by using bisphosphonates. And then a second is to diminish existing calcification using sodium thiosulfate. Important to know that neither of these are FDA approved for the use of GACI. There's no randomized controlled studies. The benefit remains uncertain. It's really tricky to understand if these are efficacious because that calcification does resolve with age, as I mentioned. And unfortunately, it does not appear that either medication, even though they may prevent or help with calcification, it doesn't seem that they do anything to treat the arterial stenosis. So let's just kind of walk through the rationale for this a bit further. So bisphosphonates, as we all know, are pyrophosphate analogs. And the first generation agents such as etidronate have greater mineralization inhibition than the aminobisphosphanates that we use now to treat osteoporosis. Unfortunately, in recent years, these medications have become harder to obtain. Importantly, bisphosphonates do cross the placenta, so these medications can be administered maternally to try to prevent some of that calcification in utero. There's a few clinical studies looking at the efficacy of bisphosphonates. This first paper by Rutsch and colleagues in 2008 was a retrospective review of 43 patients surviving beyond day of life 1. 17 of these were treated with bisphosphonates, including etidronate or pamidronate. Some started in utero, some started postnatally. They did demonstrate that there was greater survival in those patients with bisphosphonates than those who were untreated at 65% versus 31%. You can see those clear separation in those curves in this plot here. And then more recently, Carlos Ferreira looked at this in his natural history study. This was a multi-center review of 63 bisphosphonate treated versus matched untreated patients with GACI. Here is a Kaplan-Meier plot looking at this. So overall, there was no survival benefit. This curve is showing survival of the bisphosphonate treated in black and the matched controls in red. The dashed lines represent the 95% confidence intervals, and you can see the overlap of those confidence intervals. What's interesting about it, though, is you do seem to see, you can look and see, looks like there's maybe a little bit of a deviation in survival in that sort of critical early time period. So they did some further sub-analyses. They limited the analysis to those who were treated within 6 months of birth. And when they did that, they did see some separation. And it did look like that those who were treated within 6 months had improved survival at 74% versus those who were untreated at 47%. And then drilling down even further, they looked to see at a difference between those who initiated before 7 days and those who initiated after 7 days. And it turns out if they excluded those individuals who did not receive treatment within the first week of life, that significant survival benefit was lost. So again, just sort of highlighting this idea that if there is a benefit here, it really seems to be only with very early initiation of therapy. Of course, we have to think about the risks of these medications. I think we're all pretty comfortable with bisphosphonates and what they do. So it probably won't surprise you that there are some skeletal abnormalities that do come up when you treat fetuses and young infants with this condition. And here's a case report from Agarwal and colleagues demonstrating this. So this was a prenatal diagnosis of GACI due to ABCC6. Maternal etidronate was started at 26 weeks gestational age. Mom tolerated the medication just fine. Infant was born at 38 weeks gestational age. Really had minimal calcification on postnatal imaging. Unfortunately, this child did go on still to develop postnatal ischemic heart disease and did not survive. And then what's highlighted here is some of the incidental findings of the skeletal changes, and these did look reminiscent of hypophosphatasia. So you can see those radiolucent tongues there that I've circled. And postnatal labs of mineral metabolism were notable for low PPI. So just briefly want to talk about sodium thiosulfate, a medication we're probably not as familiar with. This medication or molecule was developed as an antidote for cyanide poisoning, and then has been repurposed for treatment of ectopic calcification due to its ability to chelate and solubilize calcium salts. So it's used sometimes in ectopic and aberrant mineralization due to renal failure or severe dermatomyositis. Again, very little published data. It's given as an IV infusion, typically 3 to 5 days per week, over 30 to 60 minutes. Unclear dosing, but what's typically used is what you've seen there, 12.5 grams per meter squared. Adverse effects can include emesis and some electrolyte abnormalities. Treatment duration is unclear. Protocols that are out there typically treat for 6 to 12 months. Again, appears to be potential clinical benefit on calcification, but does not seem to reduce the arterial narrowing. And there really isn't even much published data to support STS efficacy. So verdict then, so how do we decide whether or not to use these medications? And so I think, of course, these have to be individualized. These medications are off-label therapy, so we need to always obtain clear and comprehensive informed consent before using. However, given the extremely high mortality and I think relatively low toxicity of these medications, our group and others think the treatment can be offered in terms of options then. So prenatal etidronate to prevent calcification. Unfortunately, as far as I understand, it's currently off market. It's not clear if alendronate would have the same benefit as it doesn't have as much of the mineralization inhibition effect. And then thinking about early initiation of postnatal bisphosphonates or sodium thiosulfate to try to reduce any existing calcification with STS. As I mentioned, and as we've seen in those papers, really early initiation of bisphosphonate treatment within the first 7 days seems to be important if we're going to try to get efficacy. And then, really, this is always a close conversation with cardiology to help understand what is the extent of the disease and the expected clinical course. For AHR2, treatment is pretty similar to how we approach XLH with phosphate and calcitriol repletion. One thing that we don't know is if there's an increased risk of vascular renal calcification in this condition, so something just to be extra cautious about. You might think, oh, maybe we should use burosumab because FGF23 is elevated. However, there's some caution about this. There's some concerns that low FGF23 levels may actually worsen calcification. Again, thinking perhaps this is a compensatory response to low levels of PPI. And here's a case report from Stern and colleagues, which did report a 15-year-old with GACI who developed Ricketts and had ENPP1 deficiency, was initially treated with etidronate and then started on burosumab for worsening Ricketts and an elevated FGF23 level. Showed biochemical improvement, as we would expect. As you can see here, the phosphorus came up with burosumab treatment. Unfortunately, however, treatment had to be discontinued at 20 months when they saw progression of the aortic valve calcification. So you can see the baseline ultrasound here, and then what appears to be more calcification at 20 months. For PXE, again, this is mostly going to fall to our adult colleagues. Skin lesions can be treated with cosmetic measures. There's different approaches to try to deal with the ocular damage with laser and phototherapy. And then really just important to talk about the arterial calcification and be aggressive in treating atherosclerosis with lipid-lowering agents, antiplatelets, and anticoagulants. A few studies looking at etidronate, and I did find one experimental study of an oral PPI analog that looked like it might have some efficacy, but again, this is an experimental medication and not clinically available. And then really just going to end here with the future and talk a bit about the possibility of ENPP1 enzyme replacement therapy. So this work, a lot of this comes from Demetrius Braddock and his group at Yale. And here's a paper showing ENPP1 fusion protein prevents mortality and vascular calcifications in a rodent model of GACI. A couple of figures sort of highlighting this here. So this is subcutaneous administration of the ENPP1 or enzyme replacement. In the first panel, you can see looking at the plasma levels of PPI, again, undetectable in the affected mouse, and they come up to close to normal and even above normal compared to the wild type. And then also seeing some tissue samples here showing improved calcification. Oops. So this again would be the untreated mouse with significant intracardiac calcification. And then this is the treated mouse with absent calcification there. This drug has then been acquired by Innazim, who is then developing with the intent to commercialize. And so here is a couple of their papers demonstrating efficacy of their product. So this first is Innazim 701. It's what it's now called, preventing ectopic tissue calcification and restoring bone architecture and growth in ENPP1 deficient mice. Similar to what I showed you from the past paper, we can see a nice improvement in plasma PPI compared to the affected mouse. And then also we see decreased tissue calcium burden. The red boxes represent the untreated affected mice, and you can see high levels of calcification in the kidney, the spleen, and the lung. And then there's a dose-dependent decrease in the amount of calcification with treatment. They also noted there was improvements in bone density and structure. They did a similar study in a mouse model of ABCC6 deficiency. Same thing, we saw a nice increase in PPI here. And then again, a decrease in calcium burden, this time in skin biopsy. So again, the red represents the untreated affected mouse, and you can see the decrease in calcification with treatment. So where they are currently, there's 2 clinical trials ongoing in humans. This is from clinicaltrials.gov. So safety, tolerability, and efficacy in adults with PXE and adults with ENPP1 deficiency. And there's a study in infants with GACI due to ENPP1 deficiency in development. And then let's really look out into the future, thinking about the natural history and course of this disease. We're probably talking about prenatal treatment is what we really need. And that might sound really far out, but just want to highlight this recent paper from the New England Journal illustrating the successful in utero enzyme replacement for infantile onset Pompe's disease. So you can imagine potentially one day, identifying these children as affected fetuses and beginning treatments early in the disease course to try to really prevent some of the devastating consequences of this disease. So to summarize then, ENPP1 and ABCC6 deficiency result in a spectrum of ultra-rare diseases, including GACI, AHR2, PXE, and coal disease. Emerging evidence suggests a possible link between ENPP1 deficiency and osteoporosis. More work to be done here. No specific FDA-approved treatment is currently available for any of these associated diseases. However, ENPP1 enzyme replacement therapy shows promise in preclinical models. Safety efficacy in humans is currently under study. Laura asked me just to do a couple case presentations because it is such a rare disease. And so I just picked 2 from our practice. I just want to briefly run through and leave some time for questions here. So first one, this is one of my colleagues, Dr. Levine's patient, and Dr. Levine really has sort of developed the clinical protocol that I've discussed here with maternal etidronate and STS therapy at our institution. This is a 30-year-old female referred to the fetal heart program at CHOP at 28 weeks gestation for suspected GACI. This mom had a previous child who had passed away from GACI at 10 days of life. Or 7 weeks of life, sorry. And so this fetus had fetal genetics done and did confirm a compound heterozygous mutation in ENPP1. So the diagnosis was known when they came. And the family was looking if there's any treatments to prevent similar outcome in this pregnancy. Prenatal ultrasound did show calcification of the aorta and iliac arteries. So here's an image of that prenatal ultrasound at 28 weeks. You can clearly see the calcification there of the aorta as well as the iliac arteries. Maternal etidronate therapy was initiated at 30 weeks gestational age at a dose of 600 milligrams BID. Calcification really did not worsen during pregnancy, a little bit hard to quantify, maybe even some improvement. This patient did deliver in the special delivery unit here at CHOP, which is designed to sort of be able to offer immediate life-saving care when needed. And infant actually was born and did not require any acute cardiopulmonary intervention. Postnatal imaging did confirm calcification in the descending aorta, iliac arteries, subclavian arteries. The coronary arteries appeared to be spared. There was also narrowing of the aorta, the SMA, the celiac, and the iliac arteries. And so because of this, the infant was started on treatment with aspirin as well as STS 5 days a week. Treatment carried on for 1 year. The calcification had essentially resolved by 1 year of therapy, and STS treatment was stopped. However, that stenosis did remain. She then went on to develop Ricketts, as we might expect. So this presents around age 2. You can see there classic signs of hypophosphatemic rickets with low phosphorus and an elevated TRP, or sorry, a low TRP, and then elevated FGF23 level. At this time, the patient was initiated on calcitriol and phosphorus. Really highlighting the excellent growth and sort of importance of sort of early identification of the rickets, and with good treatment, you can get great growth. She did go on to develop hearing loss around age 5, and that's managed with hearing aids. And then interestingly, it was just recently seen back in our clinic and actually had some evidence of some new calcification in the atrium and the mitral valve. Not entirely sure what's going on here. This is sort of not thought to be typical natural history. Didn't really look like she was overtreated from the Ricketts standpoint. At the phosphorus levels were at the low end of normal. Alk phos was mildly elevated. PTH was within normal limit. Cardiologist saw her and wasn't too concerned. There didn't appear to be any cardiac dysfunction, so no specific treatment was given, and we'll just continue to monitor this closely. Second case is one of my patients presenting at age 12, referred from orthopedics with concern for metabolic bone disease. Saw this patient with my physical therapist colleagues, and one of these patients that you just don't quite understand how it made it this long before coming to attention. This poor kid could barely walk. He had significant bilateral valgus deformity. So you can see there, patellar dislocation, as you can sort of see those patellas deviating outward. Could barely even walk into clinic. Yeah, it's pretty marked in short stature. You can see his height there well below what would be expected for his mid-parental height. He had had one prior forearm fracture as a child. That was traumatic and due to a fall, and no history of cardiac disease. So at this point, I was thinking, this is probably XLH that just hadn't been picked up. Did have some labs consistent with hypophosphatemic rickets there with a low phosphorus and elevated alkaline phosphatase. His TRP also was a little bit low. However, when we did the genetic testing with the mineralization panel, we found that he actually was compound heterozygous for loss of function mutations in ENPP1. He was started on fast phosphate and calcitriol. And he's done pretty well, so we've seen biochemical improvement, as you might expect. In terms of further evaluation, we sent for cardiac screening. His echo was normal, so no evidence of any dysfunction or calcification or stenosis. He had had audiologic testing and no hearing dysfunction. Referred to opto, hasn't been seen yet. Doesn't have any known visual disturbances. Didn't have any skin abnormalities to suggest cold disease or PXE. And then because of his significant orthopedic burden, he's had multiple surgeries, including bilateral osteotomies, patellar reconstruction. Overall, relatively good effect, and he's happy and much more functional than he was previously. So with that, I will end, and happy to